Great, thank you very much, Lori. So I just wanted to update everyone on the Division Seed grant, which initially was awarded for funding year of 2020 calendar year, but with COVID and everything else, there was an extension of that. So just wanted to kind of review this and catch everyone up to where we are in working on the USC Center of Diabetes Excellence. And really where this came from initially was thinking about what is the PT's role and how can we have an active kind of impact on our patients that have diabetes. And we looked at some of the data that was out there. And I think some of the most compelling things that we kind of recognized, especially looking at the outpatient reach of some of our faculty practices right now, is that about 80% of patients that are referred to outpatient physical therapy have either diabetes, pre-diabetes, or risk factors for diabetes. But only about 2% of the referrals to outpatient PT are for diabetes as a primary health condition to be treated. So we just felt that that was an enormous gap that we as physical therapists could really take advantage of and help our patients who might be coming in for a different orthopedic or neurologic condition, but have this underlying comorbidity of diabetes. So I've been fortunate to work with a very multidisciplinary group. Jesus here at the division has been active in this grant with me. I'm also working with colleagues across podiatric surgery, vascular surgery, and endocrinology and health policy here at USC. So we have kind of a good group together to kind of pull some of this stuff apart. One of the biggest things that we accomplished was getting our database developed in REDCap that allows us to look at PT measures, but also wound measures, and then interdisciplinary management and follow-up measures. So once these patients with a wound are closed, how much time is it taking to get them their custom footwear? How much time is it taking to get them in for some of these different follow-ups that could create issues? If we identify someone as at risk, how long is it taking them to be seen for that initial PT evaluation? Those types of things. And then we were also able to develop a dashboard, which actually has some pretty powerful implications for us just with what we're looking at kind of within the seed grant, but also I think allows us to really think towards the future of different specific research projects that we might want to work on, because we are actually able to search all of the common wound-related CPT codes that either a physical therapist or a physician would perform. And that query is all of USC patients across Keck, Norris, and Verdugo Hills. So we have a huge data subset that we are able to pull that information from and use that, which is great. So those were kind of our big two things that we needed to get from an infrastructure standpoint developed, and we were able to do that so far within the timing. This is just an update on kind of the outcomes that we've been focusing on. And a couple are partial because, pandemic, and I'll talk about that in a little bit. I would say the biggest thing that we've made a good bit of progress on has been protocol development for titrating patients' return to activity following wound closure or remission. So that protocol and those recommendations have been published this past year. And we also just received some draft patient education materials last week. So that's very exciting. And I'll kind of show you those here in a second. The level 2 training that we've been working on, that was myself, Jesus Dominguez, and David Ursig. So thank you very much to the two of them for all of their work on that project. We will be ready to roll that out to the therapists across the USC faculty practices this year yet. So that's also very exciting. These are just some samples. We've got very nice looking patient education opportunities now, and then also the research article that was published. Just to share some preliminary data, and we looked at what types of referrals are we making. So we're referring our patients once we do their risk stratification by a 3-minute foot exam to podiatry, primary care, and endocrinology as kind of our 3 main referrals out. And what you'll see here is that the highest percentage, almost 50% of the patients that we're risk stratifying are falling into this very low risk category for developing some type of a diabetic foot wound. But I think that in and of itself is actually quite powerful when you look at some of the health equity data. And that shows us that African American and Native American patients are almost at a 2 times higher risk of major amputations when they have a diabetic foot ulceration than their white Medicare beneficiaries. So timing of care is really important. And identifying patients that are in these very low or low risk categories actually gives us a lot more time and opportunity to intervene early and do something hopefully meaningful to kind of prevent them from progressing along this area. We obviously had some difficulties with COVID as far as in-person volumes decreasing, which really impacted some of our data collection. The level 2 training I spoke of needed to be converted to a completely virtual format and then reorganized with internal faculty because some of the external faculty that we had lined up were not able to continue to participate. And then we really identified, you know, the need for these patient handouts and something a little bit more robust in that sense, because we weren't seeing patients as often. So with less face-to-face, they needed to have something that they could refer to when they were at home so that they weren't having more issues. And then, as I said, we did get the extension into calendar year 2021, which has been very helpful. So as far as next steps, we're going to complete our level 2 training and continue to standardize the protocols and algorithms so that we can really kind of scale those for dissemination across multiple platforms. We're really looking at setting the standard for true team integration within kind of multidisciplinary clinics and setting up a way to successfully get reimbursed for those. And then I think this is just a great opportunity for us as physical therapists to explore primary care and some of the impact that we can make for our patients there.